Hello, it's Luke, and in this tutorial we're going to be thinking about the perfusion of the myocardium and the blood supply to the myocardium and changes and adaptions that occur during exercise when the heart rate is increased, and also changes that occur in disease processes like coronary artery disease. So to recap, here's the heart, and you can see coming out the top of the heart is the aorta, and you'll recall that oxygenated blood flows from the lungs into the left side of the heart, and the left ventricle pumps the oxygenated blood out to the rest of the body through the aorta. Well, arising from the sort of root of the aorta are the coronary blood vessels, and there's the right coronary blood vessel that mainly perfuses the right side of the heart, so the right atrium, the right ventricle. And then there's the left coronary artery that mainly perfuses the left-hand side of the heart, so the left atrium, the left ventricle. And the left coronary artery sort of feeds two large arteries, the left circumflex and, importantly, the left anterior descending. Now, all of these arteries are what we call epicardial, so they're sort of on the outer surface of the heart, and they branch out across the heart and then down within the myocardium itself. And so I've produced a diagram to aid us in our understanding from this point onwards. So here's the diagram we just saw, and we've taken a snippet through the left anterior descending and through the heart muscle itself. So here's our diagram. We've got the epicardium, so the outer edge of the heart. We've got a epicardial artery, and in this particular instance is the left anterior descending artery, and that is feeding the arteries and arterioles within the myocardium, which we've got here in pink. So we're going from the epicardial artery down into these intramural arterioles, so these are the blood vessels, the arteries within the wall of the myocardium itself, and those are then feeding the smaller arterioles and eventually the capillaries, where the gas exchange and the exchange of nutrients and toxins is occurring. And it's not all sort of going down deep within the myocardium, but obviously there'll be branches coming off across and throughout the myocardium. So you may recall that myocardial perfusion occurs during diastole, and the reason for this is that during systole there's contraction of the heart muscle, and so the vessels within the wall of the heart, within the sort of myocardium itself, get compressed by the contraction, and so there's a greater period of time, and it's roughly 2/3 to 1/3 of the time is spent in diastole when perfusion of the heart muscle is occurring, compared to systole when the blood vessels that perfuse the myocardium are being compressed by the contraction of the heart itself. And this is just a slide showing those two different phases. Now, during exercise, a couple of things happen. One is that there is an increased demand for oxygenated blood to the heart muscle, because it's having to work harder, it's having to beat with more force, it's having to beat faster. But there's also this issue where actually, because the heart is beating faster, it's spending more time, proportionally more time in systole than it had been spending so much time in diastole. And so the sort of knock-on effect of that is that actually there's less time for the blood to flow through the arterioles and sort of nourish and oxygenate the walls of the heart muscle themselves. Now, to compensate for this, flow is increased through the arterioles within the wall of the heart muscle by dilating up the arterioles within that heart muscle. So as you'll recall from other discussions about vasoconstriction, vasodilatation, if you make the lumen of the artery bigger, so if you relax the smooth muscle within the artery, then you get less resistance flow, and so you get more flow through the artery, get into the tissues. And thinking about a situation where we have less time to perfuse the myocardium, If we have then less resistance to the flow, then that means that there's as much, if not more, oxygenated blood making it to the myocardial cells themselves, because we're dilating up the arteries that supply the myocytes. We're going to talk about coronary artery disease now, and in particular atherosclerosis. So you'll be aware that you can get these plaques form, and they're full of low density lipids, so fats. They're full of macrophages that have ingested those fats and other sort of inflammatory cells. And what happens is you can build up this plaque here, with maybe a thin layer of smooth muscle over it and some fibrin and collagen that's been laid down. And this will occlude or partially occlude the arterial supply of oxygenated blood to the heart muscle. And this reduced flow through the epicardial arches will have a knock-on effect in that there'll be less blood flow getting down into the smaller arteries and into the capillaries, and so perfusion to the heart muscle itself will be impaired or could be impaired. So similar to the example that we just gave, where when there is an increased demand for oxygenated blood during exercise, the arterioles dilate. Similarly, when there's a reduced flow or a reduced flow of oxygenated blood coming through the larger epicardial arteries, similarly, there's dilatation of the arterioles within the walls of the heart muscle to improve the flow and maintain perfusion of the myocardial, of the myocytes, the heart muscle cells. And this is just another diagram saying the same thing. So it's the same group of vessels again, and in this instance we have normal tone within the artery, and so our perfusion is impaired. And in the second instance there's dilatation of the artery, and so there's improved flow and perfusion is maintained. Now, you'll recall a few moments ago we were saying that this is a compensatory mechanism for when there's an increased demand for oxygenated blood, say when the heart is having to work harder during exercise. Well, imagine the same situation where we've got both of those circumstances occurring. So we've got somebody who is exercising, so their heart has to beat harder and faster, but they also have a reduced supply of blood coming through those arterioles because of their atheromatous plaque. Well, we've already dilated up our arterioles as far as they will go to maintain supply at rest in somebody who has coronary artery disease. When we then increase the demand for oxygenated blood, there isn't anything else that can be done, that you can't dilate the blood vessels up any further, and so there's a reduction in perfusion to the heart muscle cells, causing pain, and that pain that you get related to the sort of starvation of the heart muscle cell of oxygen, and therefore it can't produce adequate ATP, doesn't have energy. You begin to develop this pain, which we would recognize in our patients as angina pectoris. So this tight, constricting pressure, central chest pain that may radiate up into the neck or to the arm or various other parts of the body. And what we know about stable angina is that when that person then rests, because the demand from the myocardium is reduced back down to normal levels, then the sort of albeit limited flow of blood from the epicardial arteries is sufficient to perfuse the tissues of the heart. However, if they are exercising or under sort of stress conditions, then they're prone to developing ischemia of the heart muscle, and that's when the angina pectoris pain occurs. Now, there's one more thing I wanted to talk to you about, and that's collateral blood supply. So there are a lot of what we call anastomoses, so a lot of joins, bridges, if you like, between neighbouring blood vessels in the heart. And this is to prevent a situation where there's hypoperfusion if one of the blood supplies becomes blocked or compromised for whatever reason. Now, these can occur in health. This is a normal sort of variation to occur. And they can also occur as a sort of chronic compensatory response to reduce blood flow through the arteries and the arterioles. So we've got two neighbouring blood vessels here, one healthy on the right hand side and one that's got a atheromatous plaque. And if we've developed blood vessels that are sort of act as a bridge between the healthy and the diseased vessel, then we can still maintain perfusion to the tissues that would otherwise have been impaired, if there was only flow coming through the diseased vessel. So here's just the diseased vessel. There's no collaterals, and we've got impaired perfusion. Whereas the healthy vessel, there's healthy perfusion to those tissues. However, if we undergo arteriogenesis, which is the formation of new arteries, and we develop this collateral blood supply, then even if this vessel is extremely occluded, then there's still good blood flow to this tissue here, even in conditions where a person is exercising and they might otherwise expect to have angina. So, in summary, we can say that blood flow through the epicardial arteries and the arterioles within the walls of the cardiac heart muscle occurs during diastole, when the heart muscle is relaxed and so those blood vessels aren't being compressed. Arterial vasodilatation is the means by which a perfusion is ensured during exercise where there is increased demand for oxygenated blood, and during coronary artery disease where there's reduced supply of blood from the epicardial arteries. However, when those two conditions occur at the same time, coronary artery disease and exercise, then somebody may experience angina, which is pain due to the insufficient supply of oxygenated blood to the myocardial cells. There's a compensatory mechanism called collateral blood supply, where anastomosis or bridges between the arteries ensure supply of blood to the myocardial tissues as well. And this can occur even during advanced coronary artery disease. Thank you very much for listening.